Hello everyone. So today we shall take a quick look at congenital syphilis. And I advise if you've not watched the general video on syphilis, you can first watch the one or for general syphilis. Then after that, you come and enjoy this one on congenital syphilis. So this is a type of syphilis that usually acquired from mother to child, either transplacentary or during the period of childbirth, especially if the mother has primary syphilis and they have maybe a syphilitic chancre in the genitalia or in the birth canal, and then the child ends up acquiring it that way. So today we shall cover how it comes about and how best we manage it. So just like the other type, this is also caused by the same bacteria, the Treponema pallidum bacteria, and as we've mentioned, from infected mother to the child, either during the when the child is still a fetus or during child delivery. So the consequences can be including things like fetal loss, stillbirth, and prematurity, low birth weight, and other disorders of infancy, including deafness, neurological impairment, as well as bone deformities. So the transmission risk, it can occur at any stage of pregnancy, and commonly we know that primary syphilis can be transmitted. Secondary syphilis can be transmitted, as well as tertiary syphilis in some cases. So the infections can occur during any trimester, and only severe cases show symptoms at birth, but most of the time the child can be normal at birth. Then afterwards, they end up showing signs and symptoms of syphilis. Then when it comes to prevention, you realize that currently during the ANC or the antenatal visit now, screening syphilis is mandatory. And in this case, when you screen and the mother is positive, you test and treat. And that is the reason to prevent congenital syphilis. So as I mentioned in the previous video, when it comes to the prevalence in 2022, WHO estimated about 7,000 cases of congenital syphilis globally. And of these, 1,500, actually 1,500,000 cases ended up in death. And then neonatal deaths are just 70,000, and those children with low birth weight and prematurity contributed to about 50,000 cases. And then infants that had symptoms of congenital syphilis, there were about 115,000 cases that were reported globally. So when it comes to demographics, it affects both sexes, male and female, equally. And severe cases, we see them usually at birth, but then later on in childhood, they can get now either the secondary or even the tertiary syphilis. So it has no racial predilection. It affects everyone, wherever you are, whatever you do, and in all socioeconomic settings, it can affect you. So when you go to the pathogenesis, as you remember, even in the previous video, we discussed that the bacteria after invasion, it will usually go to the vasculature, and then it will cause damage to vasculature by triggering an immune response, which is mediated by lymphocytes and neutrophils and macrophages, as well as histiocytes and plasma cells. That by the end of it all, we end up damaging the vasculature, whereby the vessels will now heal with scarring, resulting into subsequent stenosis and the rest. So still, we usually get obliterative endarteritis in syphilis, and the cellular features usually see mononuclear cells, plasma cells, infiltrating around the blood vessels, the intimal hyperplasia, as well as the swollen endothelial cells if you do histology. So other tissue changes, usually we see collagen deposition. We know that blood vessels heal by scarring, and then you can also get gummatous or gumma formation within the vicinity of the vasculature, sometimes with the central necrosis and fibrosis. So they can also affect other organs, as we've mentioned earlier, the liver, the kidney, the bones, the pancreas, the spleen, the heart, as well as the brain and the lungs. The agent is still the same, Treponema pallidum species. So when it comes to congenital syphilis, it is very key for you to note how the first manifestation is, because oftentimes people see this and they have no idea or no clue of what is going on. And in this period, this is the best time that you can save the child when they still have these early manifestations. So still, the very early sign in life or the very early symptom, they will be seen within the first 2 years of life. And sometimes different children can have late presentation, whereby the disease will now manifest even after 3 years of age and onwards. Then most of them, they can also develop the syphilitic stigmata, which include scarring, deformities, and the things of the saddle nose deformities and the rest, joint involvement, giving the permanent deformities and the rest. So these are the stigmata that can usually come. So you see in this picture, you see and also discharge. This is one of the most common early presentation of congenital syphilis. So the child has this discharge from the nose that is a continuous mucoid in nature, and that is what we call syphilitic rhinitis. So in the early presentation, some of the infants can be asymptomatic or may show little or no symptoms. However, they will get these proliferative vascular changes, like in the placenta, and some of them can end up with inflammation of the umbilical stump, which we call sinusitis. And this is very key for you to remember, because maybe a mother will give birth to a child, then they go, they discharge them, they go home. But then when they come back, you realize that the child has an umbilical stump that is not healing, and that can be the early sign of syphilis as well. So you have to take note of that. Then the symptoms that we usually see, they can come between 3 to 8 weeks after delivery, and oftentimes, or if untreated, you see them in the first 3 months. So the common manifestations can involve both the skins and mucous membranes, starting with the snuffles, or what we call the syphilitic rhinitis, the previous picture I've showed you. And in this case, the child will have that serous nasal discharge with high concentration of T. pallidum. It can even be infectious with the other children around home, or even other people who are maybe carrying the child. So because of this, every time you see this, there's a risk of the child getting involvement of the hard palate and soft palate, so they can end up with a sudden nose deformity if you're not treated very well. Then they can also get mucus patches, especially on the tongue and the hard palate. You can be sometimes erythematous or even nodular in the setup. But on the skin, in the early congenital syphilis, we see the similar lesions that we see in adults. The copper red rash that especially also affects the palms and soles as well, that resembles the other type of acquired syphilis that we see in adults. Then it is also possible to get eczematous or epididymised or even gangrenous lesions in early syphilis. As I told you earlier, this is a great mimicker that it looks like all other skin conditions. So these lesions will heal, and then they will give you catalytic ruggets or scars, which we usually see along the oral mucosa. Then along the perioral mucosa. Then we can also get pemphigus syphiliticus, whereby in this case we get bullous lesions that affect the palms and soles. So now this will mimic other bullous conditions like the pemphigus vulgaris, like the bullous drug eruptions and the rest. So you need to also take note of this pemphigus syphiliticus that you can see in early congenital syphilis. We can also get bone abnormalities, including diffuse periostitis and the osteochondritis with a positive Wimberg sign. This one you're going to usually see it on X-ray, where you have now defective or loss of denseness, where you have lytic lesions involving the bones, especially at the distal end of these long bones. Then at the end of that, you have destruction of either the metatarsals or that cartilage that is supposed to give rise to the newborn. So if you misdiagnose this, you can think it is either rickets or even because of trauma, but you have to remember that syphilis now is also part of your differentials, now causing durations that can make you think it is trauma. So this is also very key. As you manage, doing an X-ray, and then the child has X-ray which shows trauma and with a fracture, but then the child does not show trauma. So you have to think about syphilis. Then other systemic signs like pneumonia, you can get hepatosplenomegaly, you can get jaundice, anemia, thrombocytopenia, as well as neurological involvement like meningitis, meningoencephalitis, seizures, and intellectual impairment can also occur. Then can also involve the eyes, then you end up with chorioretinitis or even chorioiditis. So when you look at the features of these either early or late congenital syphilis, you can now tell for differentiate them. As we've said that if it is early syphilis, the presentation can never be even certain from stillbirth, death, low birth weight. Then later on, if the child is actually survives, and then the early presentation within maybe the first 3 to 8 weeks, they can get the snapholes. Those are the syphilitic rhinitis. They can now get a maculopapular rash, which is similar to the ones we see in adults, that copper red rash, then involving the palms and toes. Then you can get papules, you can get uh, mucus patches. They can also get condylomata lata, then vesiculobular lesions, the one we called pemphigus syphiliticus. Then they get rugged. Those are scars that are usually here around the perioral area. Then they can also get desquamation, which usually affects the palms and soles with the scaling. Then they can also get alopecia, as we saw in the other presentation in the adults, where they get the moth-eaten type of alopecia. Then later on in the immune system, under early presentation, they can end up with a hoarse cry, uh, uh, and then they can get ocular involvement, where you get things like glaucoma, uveitis, and then chorioretinitis. Then gastrointestinal system can also be affected. You end up with pancreatitis, enteritis, and then hepatosplenomegaly. Then when it comes to the kidney under still early, we can have nephritis, we can have edema and even ascites. Lymphitis can come up with lymphadenopathy. And then in the blood, you can get a thrombocytopenia, anemia, and then even DIC. When it comes to the CNS, you can get a septic meningitis, you can get chronic meningeal vascular syphilis, and then cranial nerve palsy, and then even hydrocephalus. When it comes to the bones, you can also get the periosteitis as well as osteoarthritis involving the bones. But when it comes now to the late presentation, now these are the syphilis that you see in late congenital syphilis. You get rugged, you can get stigmata, you can get even palate perforation, like the picture I showed you in the previous video. You can get the Hutchinson's teeth, and we're going to see how they look like. Then you get the Melbury molars, and then interstitial keratitis, uveitis, then glaucoma, and then mental delay, eighth nerve deafness. You have the Hutchinson sign, which combines eighth nerve deafness. Then you have the Hutchinson's teeth together with another fish I'm going to tell you. So you have other things that we usually see. You can also get the Clayton joint, the sudden deformity, the short maxilla, and then protuberant mandible. And then you can also get thickening of the medial part of the clavicle, and that one usually has that hard Chinese name. And then you can also get the subraetabe, that involves the nerve down at the end of the terminus of the spinal cord. So these other table still emphasizes the same things. In early syphilis, these are the manifestations you see, the nasal discharge and the rest. So you can just pause the video and then you go through one by one. So someone can trick you a question and then they ask you, maybe write short notes on the wishes manifestations of maybe early syphilis. Then you'll have to highlight these features that you see here, the dactylitis, periosteitis, then osteochondritis. So those are the things that you have to highlight in that case. So when you go to late congenital syphilis, in this case, this will arise from an inflammatory response to the early pneumo infection, and it will include things like skeletal defects, then facial characteristics, characteristic lesions. You can get dental anomalies as well as neurosyphilis, as you say in the adults. So this one poses a diagnostic challenge because you have to distinguish it from the late acquired and then the later types of syphilis, which you can only do through a thorough history taking and then examination coupled with laboratory investigations. Then, when it comes to skin and mucous membranes, you'll get eruption that resembles the nodular syphilis and the stigmata, as well as the pericytis of the acquired syphilis that we've seen earlier in the previous video. And then the characteristic signs, usually about 5 to 16 years, the child will develop now this interstitial keratitis, being one of the late common presentations of the late congenital syphilis, with bilateral corneal clouding, as well as things like photophobia. And then oftentimes this can even require use of corticosteroids to try and salvage someone's vision. Then they'll get the Clapton joints, which are usually painless knee synovitis, which most times resolve actually without treatment. So when you go to the bones, we get the tabae, and in this case, you can also get clavicle changes, scalp lesions, stigmata causing hard palate perforation. You can now end up with also as well as eighth nerve deafness, which is most of the times bilateral, neurolimbilinitis, that word, following keratinitis with tinnitus and then progressive deafness. So syphilis is a little bit hard to diagnose, especially in children, because the presentations there's not as that easy to remember. But at least when you have an idea, and then when you do your test, you can now come to a conclusion that this is actually syphilis. So other manifestations, including the neurosyphilis in children, that one can now come a little bit later, about 6 to 21 years. So someone can come with similar things that we saw in adult or in the acquired type of syphilis. We can get the juvenile generalized paralysis, cerebrospinal abnormalities. You can also get cardiovascular involvement, although they are a little bit rare when it comes to congenital syphilis. And it is very key for you to do an eye ophthalmology referral because of the bad keratitis that comes in this type of syphilis. So in this picture, I wanted to show you a summary of the signs that you see in late congenital syphilis. So the first one is the Clapton joints. In this case, you get an infusion that is usually painless of the knee joints, as you can see in this animation here, that reddening and swelling of the knee joints. Then you get eighth corneal nerve deafness, so the child will not be able to pick sound. Then you get fibrosing, frontal fibrosing, which is usually here. Then you get the gumas on the skin. Then you get this, how do you read this? Higumaneki's sign, which we usually call, which involves the swelling of the medial aspect of the clavicle. Then we also have the Hutchinson's teeth, which are peg-like shaped upper central incisors, and then you also get things like hydrocephalus, interstitial keratitis, mental retardation, then the Marlberry molars. You know, Marlberry is a berry, a type of berry like this. I put it for you there, and that's how the teeth will look like. If I imagine 5 for you, that is how the teeth will look like, and this is how those berries look like. So at least you should remember that one. Then we can get ocular changes. Then we can also get ruggets, which is usually scarring around the mouth, like here. Then you can also get the sebaceans, which is usually around down here. And then you can also get short maxilla, and then also the saddle nose deformity. So these are the ones at least you can remember one by one, slowly by slowly, until when you can be knowing the entire list. So still when you're doing diagnosis, the evaluation still similar to what you saw in adults. You can do dark field microscopy, you can do histological examination, where you take off even part of the placenta and the cord, and then you examine them for the presence of spirochetes, either using dark field microscopy or you can use the direct immunofluorescence or immunohistochemistry. Then you can do radiographic imaging, where you do long bones, you do X-rays, and then try to see if there's any lytic lesions. Then you can as well do the serology, where you can employ both either the treponemal or the non-treponemal tests. And then for children, you have to as well do a CSF analysis to see if there's any involvement of the CNS. So this is how the picture will look like. Now you see this in the first picture here. You're having a child with congenital syphilis, now presenting with these papillosquamous lesions on the skin, but also extending to involve the. And now these are the deformed incisors, which we call the Hutchinson's incisors. This is now the Mulberry molars. Then here you're getting a loss of hairs along the eyebrows, and then also this papillosquamous rash on the face. Then palmoplantar scaling. The scaling, you also usually see it in congenital syphilis. So this one was trying to show you this saddle nose deformity from an angle, and then you can also get Mons molars. In this case, you have that depression of the molars at the center, which appears to be loss of the cusps or those indentation on the teeth. So the teeth now become very, very small. So when it comes to treatment, you can give IV penicillin G. In this case, you can give between 100,000, 150,000 units per kilogram body weight, given twice daily for about 7 days. Then you can give 3 times for 3. Then you can give 3 times for about 3 days. Then you can also give IV procaine penicillin G at 50,000 international units per kilogram body weight per dose. This one can be given once a day for about 10 days. And then if someone has CNS involvement, then you step up the dose. The crystalline penicillin G, you go to 200,000 to 300,000 units per kg. This is given per day. You can divide the dose to give either 3 to 4 times or 3 to 4 times per day. This can run for about 10 to 14 days. Then these children should be followed up, and then you have to do a follow-up at 1 month, 2 months, 3 months, 6, and then after 6 months to make sure that they're okay. So that was a short review of congenital syphilis. But remember, to better understand this video, first watch the one on syphilis, which is well detailed on how syphilis comes about, how it causes disease, and how it presents variously in different individuals. Thank you very much. God bless you.